Good morning, everyone. Thank you for joining us today to discuss Medicare Part A. My name is Karen Curtis. I am a provider outreach and education specialist here at WPS. I am joined today by my friend and coworker, Bailey Lawson. Bailey's going to be helping me out today by monitoring the chat for questions that you may have and also providing some additional information during the presentation. We do have a couple of things to cover before we get started. The Training Center webpage is where you can find information related to the Provider Outreach and Education team. A copy of today's slide presentation is available for download on the live events page. There you can find upcoming education, links to register for those webinars, and in the column titled Materials, you're going to find a link to the PowerPoint slides that we show during our events. The Training Center is also home to our Encore Presentations webpage. All of our webinars are recorded, and if there's no technical difficulties, then the videos will be posted to our Encore Presentations webpage, along with our YouTube channel. Videos are available for up to 90 days, and they can be watched on our webpage without you having to go to YouTube. We know that some of you may not be able to access YouTube from your company computer, and we want you to be able to receive the education that you're interested in. Now, after 90 days, the videos will be removed from the Encore presentation webpage, but they will remain on our YouTube channel, and that will be out there until either the webinar is redone or if some information changes. Later, there will be a question and answer session if time permits. If you have questions related to today's topic, please send those using the chat. If there's any questions that I don't get to, or if there's some that maybe I need to get some more information for you, then I will email those out to everyone in attendance and provide answers. Our goal is to provide you with an excellent customer experience. We want to know how we're doing, so later in this presentation, you will be given the opportunity to provide feedback on today's event. This is your chance to let us know what we're doing right. Let us know if you feel there's areas where we can improve. It also gives you a chance to give us input on what types of education you'd like to see in the future. And while this is a CMS survey, WPS does look at our results, and we do our best to make the improvements that you ask for. Now here at WPS, we do our best to provide you with accurate, up-to-date education. I will say that Medicare rules and regulations can change. So for this reason, the CMS website should be checked for updates, and the federal regulations are going to take priority over anything presented today. Lastly, I need to let you know that CMS does prohibit the recording of this webinar. We're recording this event so it can be posted as an encore presentation. The recording will be available next week, so if there's anything you'd like to review or any information that you'd like to share, that will be out there for you. Now, while this webinar is geared towards those who have less than 6 months of Medicare experience, everyone is welcome. I'm going to cover the basics of Medicare Part A. I'll provide some definitions of terms that you will hear when dealing with Part A. I'll discuss patient liability and talk about some covered medical services. So we'll start out with defining some of the terms. Medicare is a federal health insurance program that helps individuals 65 and older with the cost of health care. There are people under the age of 65 that can also be eligible. This includes those that have received Social Security disability benefits for 24 months, those who have permanent kidney failure, which is known as end-stage renal disease, or who have ALS, also known as Lou Gehrig's disease. Medicare is paid for through 2 trust fund accounts that are held by the U.S. Treasury. The Hospital Insurance Trust Fund pays for Medicare Part A, while the Supplemental Medical Insurance Trust Fund pays for Medicare Part B and D. And you may be wondering, where does the money come from? Well, the main source of funding comes from payroll tax. So you're going to see this on your pay stub as a FICA tax. The full name is the Federal Insurance Contributions Act, and the money funds Social Security and Medicare. Now, other sources include income taxes paid on Social Security benefits, interest earned on trust fund investments, and Medicare Part A premiums from people who aren't eligible for premium-free Part A. Now, Medicare is divided into two parts. We have Part A and we have Part B. Part A is referred to as hospital insurance. It pays for medically necessary inpatient care at a hospital, skilled nursing facility, and religious non-medical health insurance institutions, as well as some home health care and hospice. Not religious non-medical healthcare institutions might not be a term that everyone is familiar with. These institutions provide care and services to people who don't accept standard medical care because of religious beliefs. It's not something that we see very often, and there are some additional requirements associated with receiving care. Um, for example, there's a utilization review committee, and they have to agree that the beneficiary would require hospitalization or skilled nursing care if they were not at a religious non-medical health institution. They also have to file a written election in order to receive care at these facilities. So there are some extra hoops that people have to jump through, and it's just not seen very often. Now, when we say Medicare covers inpatient hospital care, there are quite a few types of facilities that are included in this benefit. Acute care hospitals are facilities that focus on providing short-term medical and surgical care. Their goal is to stabilize patients and manage acute conditions so that the patient can be discharged, or they can transition to another facility for further care. These hospitals provide emergency and trauma care, but they also have specialized areas such as intensive care units. Critical access hospitals are designed to address the healthcare needs of rural areas where there may be limited access to larger hospitals. Certain criteria must be met in order to be considered a critical access hospital. The facility must be located in a state that has established a state Medicare Rural Hospital Flexibility Program and be designated by the state as a critical access hospital. The facility must be located in a rural area or an area treated as rural. It should be more than 35 miles from the nearest hospital or 15 miles in areas with mountainous terrain or only secondary roads. There can be no more than 25 inpatient beds, and the average length of stay should be 96 hours or less. Lastly, the facility must furnish 24-hour emergency care services 7 days a week. Now, inpatient rehabilitation facilities are also referred to as IRFs, so you might hear that term being used. There are freestanding rehabilitation hospitals, and there are rehabilitation units in acute care hospitals. IRFs are designed to provide intensive rehabilitation therapy to patients who are recovering from a serious surgery, illness, or injury. Individuals who are admitted must be able to tolerate at least 3 hours of rehabilitation services per day. Inpatient psychiatric facilities can also be freestanding, or they can be distinct units within an acute care or a critical access hospital. The primary focus is to provide psychiatric services for the diagnosis and treatment of mentally ill individuals. Patients should have a psychiatric principal diagnosis and require treatment at such an intensity that it can only be provided in an inpatient hospital setting. Last, we have long-term care hospitals. These are hospitals that focus on patients who need inpatient care on average of more than 25 days. Many of these patients transfer from intensive care units and they have more than one serious condition. Examples may include traumatic brain injury or organ failure. So these patients require a level of care at the same intensity as a hospital environment, but they need to have that care for an extended period of time. Skilled nursing facilities, which you will also hear called SNFs, is another benefit that's provided under Part A. SNFs are commonly part of a nursing home, but they can be a unit of a hospital. You might also hear the term swing bed. So a swing bed refers to a hospital bed that can be used for both acute care and skilled nursing facility. I don't want to cause any confusion. I just want to throw that term out there because it's something you're most likely going to hear. Now, skilled nursing facilities provide 24-hour medical and rehabilitative care for patients that are recovering from an illness or an injury. The goal is to provide care to help individuals regain their independence and prepare them to return home. Services must be received in a Medicare certified facility. This means that the facility has to meet the Center for Medicare and Medicaid Services standards and requirements to participate in the Medicare program. A doctor must determine that the patient requires daily skilled care in order to improve or maintain their current condition. Some of you may be wondering what is considered skilled care. And it's care that requires a qualified technical or professional health personnel. For example, an RN, an LPN, physical or occupational therapist, or a speech language pathologist or audiologist. I personally always remembered it as the person providing the care has to have some sort of degree or certification. It's not care that like I could provide to somebody. So that was always something that I kind of used to help me remember what skilled care meant. Now, additional requirements for SNF care is that the patient needs to have been an inpatient in the hospital for a medically necessary stay of at least 3 calendar days. And then upon discharge from the hospital, they need to have been transferred to a SNF within 30 days. So we have a 3-day hospital stay where they have to be an inpatient, and then once they get discharged, they have to be transferred to that skilled nursing facility within 30 days. Well, hospice services are covered under Medicare Part A for patients that meet specific conditions. A doctor must certify that the patient is terminally ill with a life expectancy of 6 months or less. The patient must accept palliative care instead of care to cure their illness. So the care is going to switch more to an approach that aims to improve the quality of life for the time the patient has left. I've listed a few examples of services that could be covered. It will depend on the patient's plan of care, but it can include things that you see here, along with therapy services, medical supplies such as bandages or catheters, and dietary counseling. So again, that's all going to depend on that patient's plan of care. Now, WPS does not process hospice claims. For the areas for J5 and J8 areas, CGS processes hospice claims for Iowa, Kansas, Missouri, and Nebraska. NGS processes claims for Michigan, and Palmetto GPA processes the hospice claims for Indiana. Home health is another benefit. To qualify for home health benefits, there are certain requirements, again, that must be met. First, the beneficiary must be confined to his or her home. Now, when Medicare uses this description, they're not saying that the beneficiary can never leave their home. What they mean is that the patient has difficulty leaving their home. Maybe they have a wheelchair or a walker, so they require assistance to leave. Or maybe they have a medical condition where the physician has recommended that they don't leave their residence. Um, or maybe they normally are not able to leave their home without major effort. So again, it's not that they can't leave, it's just that it's difficult for them to leave. The beneficiary must be assessed by a doctor or other healthcare provider face to face before they can certify that the patient needs home health services. Coverage is for intermittent care, which is defined as less than 8 hours each day or less than 28 hours each week. Therapy services are common, but skilled nursing care can also be included. Home health claims also are not processed here at WPS. The hospice contractors that I mentioned earlier are also those same MACs who process the home health claims. And when it comes to Medicare eligibility, entitlement is determined by one of two agencies. We have the Social Security Administration and the Railroad Retirement Board. The Social Security Administration is an agency of the federal government that is responsible for administering the Social Security program, which provides social insurance benefits for Americans. The Railroad Retirement Board is an independent federal government agency, and they administer retirement, survivor, unemployment, and sickness benefits for railroad workers and their families. Medicare Part A is free if the individual or their spouse has worked at least 10 years and has paid Medicare taxes. So remember that FICA tax that we talked about, that's paying, that's funding Social Security and Medicare. So if we pay into that for at least 10 years, then we will not pay a premium for Medicare Part A when we turn 65. Individuals who have worked a minimum of 7.5 years will pay a reduced premium, while those who have worked less or who have exhausted their Social Security disability insurance will be required to pay a full premium. For 2025, those amounts can be between $285 up to $518 per month, depending on how long the patient or their spouse paid Medicare taxes. And next, I want to talk about a benefit period. A benefit period is a way to measure a patient's use of inpatient hospital or skilled nursing facility services and to determine out-of-pocket costs. A benefit period is going to begin the day a patient is admitted, and it ends when they've gone 60 consecutive days without being an inpatient at a hospital or a skilled nursing facility. Well, at the beginning of the benefit period, the patient's going to owe their inpatient deductible. So I want you to notice that I said at the beginning of a benefit period and not yearly. So this means that a beneficiary could have owing that inpatient deductible more than once a year. After that, patient liability will depend on how long they stay at the hospital or the skilled nursing facility. Let's start with hospital days. So after paying the inpatient deductible, the patient's not going to owe anything for days 1 through 60. Days 61 through 90 are called coinsurance days, and the patient's going to owe a set coinsurance amount each day, and then the rest of the medically necessary charges would be considered by Medicare. Days 91 through 150 are what is called lifetime reserve days. Again, there would be a set cost per day, but this time it's going to be a little bit more than that coinsurance amount. And then after day 150, the patient's going to be responsible for all costs. You'll also see that I have put lifetime psychiatric reserve days on this slide. Medicare will cover up to 190 days of inpatient psychiatric care under Part A. So earlier I mentioned that inpatient psychiatric facilities can be freestanding or they can be distinct units within a critical care hospital or an acute care hospital. So in order to use these lifetime psychiatric reserve days, the patient would need to be treated at a freestanding psychiatric hospital. Next, we have the skilled nursing facility days. So when a patient is admitted to a skilled nursing facility, as long as the inpatient deductible has been paid for the benefit period, the Benny will not owe anything for days 1 through 20. Now, days 21 through 100 are considered coinsurance days, and the patient would be responsible for a set amount per day. Then, starting at day 101, the patient is going to be responsible for all costs. Now, we talked about ending a benefit period. So once they've had a 60-day time frame where that's passed and the beneficiary has not received any inpatient care, then that benefit period is going to renew. So patients are going to get back all of their full and their coinsurance days that were used during their last benefit period, and those they're going to be able to use on their next inpatient stay. Amounts owed for using benefit periods does change each year. Usually it's a slight increase, although I have seen years where it has remained the same. There is an exception to this renewal of days, and that occurs with the lifetime reserve and the lifetime psychiatric reserve days. So kind of like the name states, it's a lifetime benefit. So that means they can only be used once, and beneficiaries don't have to use them all at once. So there were times when I worked in the systems department and we'd look at a beneficiary's records and maybe they still had 50 lifetime reserve days left. So it's not an all or none thing. Now, I had mentioned that lifetime reserve days are not replenished when the benefit period is renewed. For that reason, hospitals are required to notify patients who have already used or will use 90 days of benefits. You need to let them know that they don't have to use those lifetime reserve days as part of their stay. Now, the hospital notice should be given when the beneficiary has 5 regular coinsurance days left, and they are expected to be hospitalized beyond that point. Now, patients can change their mind as long as the hospital has not filed a claim for services that might be covered under Part B. So if the patient tells the hospital, I don't want to use those lifetime reserve days, hospitals can file claims for services that would be covered under Part B Medicare. So as long as that claim has not been filed, the patient can go back and said, okay, wait, I want to use my lifetime reserve days. And so everything would get billed on those Part A claims. Well, bundling is a term that refers to a single payment provided for a defined episode of care, and it can cover multiple providers. So you may be wondering, what is an episode of care? It is a specific period of time during which a patient receives care for a specific medical condition or a procedure. It's a way of grouping all of the related services together into a single payment. The idea is to encourage better coordination and potentially reduce cost. Providers are reimbursed a fixed amount rather than for each individual service. So for example, CMS will get together with providers and payers and employers, and they'll determine an episode of care for a particular service, as well as a target price for all the services that would typically be provided for that service. So let's say, for example, a bundle payment, which is going to it's actually going to be the determined target price. So if we have a bundled payment for a total knee replacement, this one payment is going to cover all the costs associated with the surgery, including the hospital stay, the surgeon's fees, anesthesia, physical therapy, and any necessary follow-up care within a specific time frame. And the last term that I wanted to define today is respite care. Respite care is short-term inpatient care that is provided to an individual in order to relieve family members or others who would normally provide care at a patient's home. Services must be provided by a Medicare participating hospital or hospice inpatient facility or a Medicare participating nursing facility. The type of care can only be provided on an occasional basis, and Medicare will not reimburse more than 5 consecutive days. These services are usually arranged by the hospice provider. So next, we're going to move and we're going to start talking about patient liability. Earlier, when I was discussing a benefit period, we went through the different hospital and skilled nursing days that were included. When a patient begins a benefit period by being admitted into a facility, they're going to be responsible for the inpatient deductible. So for 2025, that amount is $1,676. Again, this is subject to change annually. Now, after that deductible is met, we have the days 1 through 60, which are the paid in full days, so no charge to the patient for any covered services. For days 61 through 90, the patient is going to be using their coinsurance days, so they're going to be responsible for $419 per day. Days 91 through 150, those are those optional lifetime reserve days. And if the patient chooses to use these days, then they're going to be responsible for $838 per day. And then again, after day 150, the patient's responsible for all costs. For the skilled nursing facility, as long as the inpatient deductible has already been paid for the benefit period, the Benny will not owe anything for those first 20 days. Now, days 21 through 100 are considered coinsurance days, and the patient is going to be responsible for $209.50 per day. Then starting on day 101, the patient is going to be responsible for all costs. For home health care, all covered home health services, the patient's not going to have to pay anything. For durable medical equipment, such as wheelchairs, hospital beds, and other equipment, the patient is going to owe 20% of the approved amount. The Medicare approved amount is going to be the total fee that Medicare has deemed appropriate for a specific service or item. And when a provider accepts assignment, meaning that they have agreed to accept the Medicare approved amount as payment in full, then patients would only be responsible for a 20% coinsurance after the deductible has been met. If a beneficiary receives hospice care from a Medicare approved hospice provider, they pay nothing. If respite care is utilized, then the patient will owe 5% of the Medicare approved amount, which cannot exceed the yearly inpatient deductible amount. There is also a $5 copay for each prescription for outpatient drugs that would be used for pain management or for symptom relief. Now, there are some services that are not covered by Medicare. I will tell you, medically reasonable and necessary is something that you are going to hear a lot when you're dealing with Medicare. Services that are not deemed to be medically reasonable and necessary will not be covered. Private rooms is something. Medicare pays the same amount regardless of what type of room the patient is in. In general, private rooms are not covered by Medicare. Now, there are some exceptions. If a private room is needed for isolation, if that's the only room available at the time of admission, or if the facility has only has private accommodations. So in these cases, medical necessity will be deemed to exist and it will be covered. Personal comfort items cannot be billed to Medicare. These would be items that are not considered necessary for treatment of a medical condition. Custodial care. When we were discussing skilled nursing facilities, I mentioned that patients need to be receiving skilled care, which can only be provided by a person who is trained to perform certain services. Custodial care is non-medical assistance. This is usually to help with daily living activities. So things such as bathing, dressing, eating, getting in and out of bed. This type of care is not covered by Medicare. Cosmetic surgery is not covered. Now, there are some exceptions. Medicare will consider surgeries that are done because of an accident, an accidental injury, or to improve the function of a malformed body part. An example would be patients who have droopy eyelids, like to the point where they're causing vision issues. I know when I started out as a claims examiner, this was a long time ago, but everything was sent in paper. So there was a lot of times that we would get medical documentation and they'd have pictures of patients' eyes and they would show where, their eyelids were affecting their vision. So things like that would be considered by Medicare. Routine services and supplies. These are items such as bandages, gloves, masks. Items such as these are considered to be included in the general cost of service or facility fees, and it shouldn't be billed separately to Medicare. So now let's move on and we're going to talk about some covered medical services. This is our last section that we'll be covering today. So again, we see medically reasonable and necessary. This really is the basis when providing services to Medicare beneficiaries. Uh, Doctor's orders is a way for Medicare to determine that the services were medically reasonable and necessary. This starts off with admission. A Medicare beneficiary is considered an inpatient when an order for inpatient admission has been issued by an ordering practitioner. If the order is not properly documented in the medical records prior to discharge, then the hospital should not submit a claim for Part A payment. Now, the same goes for labs and diagnostic services. An order serves as communication from the treating physician or practitioner as requesting that what tests should be performed on the beneficiary. Now, this can come in different forms. The order may be a written document signed by the treating physician or practitioner. It can be hand delivered, it can be mailed or faxed. Orders may also be given via telephone or fax. Now, if an order is given via telephone, it must be documented in the patient's medical records. While orders are not required to be signed, the physician must clearly document in the medical records their intent that services be performed. That's another thing that you're going to hear a lot in Medicare is documentation. Everything has to be medically reasonable and necessary, and it has to be documented in the patient's records. Accommodations. We touched on this a little earlier in the webinar. Medicare pays the same amount for routine accommodations, whether the patient is in a medically necessary private room, a private room that's not medically necessary, a semi-private room, or ward accommodations, although I'm not sure very many hospitals have wards anymore. Now, in general, Medicare covers the cost of a semi-private room. If a provider has both private and semi-private rooms, the patient can be charged the differential for a private room if the room is not medically necessary or if the patient requests to have a private room. The provider has to inform them of the amount that would be charged at the time of the request. Meals are also, meals that are provided by the facility are also covered during an inpatient stay. Hospitals come around, they give patients breakfast, lunch, and dinner. So those are all going to be included in that inpatient stay. Nursing and other related services ordinarily furnished by the hospital for the care and treatment are covered under Part A. Services, nurses, non-physician anesthetists are also covered under Part A when the services are provided to an inpatient. Medical social services, which contribute to the treatment of the patient's condition, are covered. This can be services to assess the patient's social and emotional factors in relation to their illness. What are the patient's medical and nursing requirements in their home situation? What financial and community resources are going to be available upon discharge? These are all things that a medical social services worker may come and discuss this during the hospital stay. Physical, occupational, and speech language pathology. Last year, my dad ended up in the hospital having his gallbladder removed. And while he was in the hospital, he received visits from both physical and occupational therapists. So they would come in every day. They'd make sure that he got up and that he walked around. They'd perform some strength exercises while he was there, just to make sure that his body kept moving. So those types of things are going to be covered during that stay. Drugs and biologicals that are given to the patient during their stay, again, must be medically reasonable and necessary for the diagnosis or treatment of the injury or illness. Use of the drug or biological must be considered safe and effective. Those that have been approved for marketing by the Food and Drug Administration are considered to be safe and effective, and they should be administered on or after that FDA approval date. Take-home drugs in general, Medicare does not cover take-home drugs under Part A. An exception would be if the patient's given like a limited supply at discharge just to get them through until a prescription can be filled. Supplies, appliances, and equipment, which are ordinarily furnished by the hospital for the care and treatment of the beneficiary solely during the inpatient hospital stay, are covered inpatient hospital services. Now, of course, there are situations where these items are going to leave the hospital with the patient. For example, pacemakers, artificial limbs, those are permanently installed. This is also true for temporary items such as tracheotomy or drainage tubes, which are necessary in order for the patient to be released from the hospital. Other diagnostic items or services that are ordinarily furnished to inpatients by the hospital or by others under arrangement made by the hospital are covered. I've listed some examples here. Again, these tests and services should be deemed medically reasonable and necessary by a physician, and they should be related to the patient's condition. So, a lot of times patients can go into the hospital, maybe they're having breathing issues, and so x-rays or scans need to be done in order to determine what's wrong. Those kinds of things are going to be covered in an inpatient stay. And we have gotten through the formal part of the presentation, so I do want to ask Bailey if we have had any questions that have come through in the chat.
Karen, there have been no questions in the chat so far.
Great, thank you so much for checking. We'll go ahead and move ahead then. After the close of today's webinar, you will receive a thank you for attending email. There are two sections I would like to call your attention to. The first section, titled Your Opinion Matters, this is going to give you another opportunity to provide feedback if you've not already done so. The second section, which is titled Certificate of Achievement, this gives you proof of attendance and contact hours, and those can be submitted to your accrediting organization for continued education units. If you do not get this email, please check your spam or junk folder. You will also need to add messenger@webex.com to your safe sender list to avoid issues in the future. Now, if you joined by phone, you will not receive this email. So in that case, please send an email to the education mailbox with your name and phone number, and give us the phone number that you used to join so that a certificate can be emailed to you. Now, if you do think of any questions after the webinar, you do have 7 days to send those in. You can email those to the education mailbox shown here on the screen. Be sure to put today's topic in the subject line so that staff knows that your question is related to this webinar and they will send it directly to me. If you have a question that is claim specific, if you have already submitted claims and things have happened, then those should go to customer service. When you disconnect from the webinar, you will be redirected to a CMS survey. I'm also having Bailey add a link into the chat. Your feedback really does mean a lot to us. We review what you have to say and we do our best to make the changes that you ask for. Again, this is also an opportunity for you to let us know if there's specific topics that you want us to provide education on. So if you have something that you really want us to hold a webinar on, please let us know that. Now, the redirect does look like what you see here at the bottom of the screen. We don't have control over how this appears, so we just want you to know that it isn't spam or anything malicious. We have made some recent changes based on survey comments that we want you to know about. Chapters have been added to our encore presentations in YouTube. These timestamps allow you to, they are located within the description of the webinar, and it allows you to skip to sections that you may want, or review something that you may want to see. Training indicators were recently added to the description of our webinars to help you decide if the material applies to you. Although you can usually tell from the title, training indicators will let you know if the material being covered is clinical, billing related, whether it pertains to Part A or Part B. I know the one for this webinar had an NTM, which is new to Medicare. So it just gives you a little extra information to let you know if it's something that you'd want to be interested in. Last month, we did hold our first Medicare Education Expo, which was an all-day event consisting of multiple webinars. Because of your feedback, the day was dedicated to education on LCDs and NCDs. This is a topic that has come up on multiple surveys as a future education topic. Now, if you weren't able to attend the event, or if you'd like to review the information that was presented that day, we did create a Medicare Education Expo playlist on our YouTube channel, and the individual webinars can also be found on our Encore Presentations webpage. Well, that brings us to the end of today's presentation. On behalf of myself, Bailey, and the Provider Outreach and Education team, I would like to thank you for being here today, and I hope that you will join us for future events. You may now disconnect.